What else? Tandaan po natin that the patient with increased ICP may have problems with the level of consciousness. So usually, first sign nila ay unconsciousness or changes in your sensorium. So therefore, you have to provide or you have to institute your safety precaution. Okay. In addition to safety precaution, we need also to provide your non-stimulating environment. So what are the guidelines for non-stimulating environment? Guidelines natin, the lights should be dimmed or the room of the patient should be darkened. Okay. What else? Aside from that, kailangan we need to lower the noise level. Kailangan it should be of quiet and non-stimulating, a calm environment. And of course, we need to limit visitors. Okay, so that is a non-stimulating environment. Okay. What else? Aside from that, when we take care of a patient with increased ICP, be sure to apply universal precaution. Universal precautions such as hand washing, wearing of PPEs or personal protective equipment because the patient would be at risk for infection. And what would be the problem pag naging infected ang pasyente po natin? If the patient becomes infected, such as a patient had a respiratory infection, coughing, sneezing, blowing of the nose, will occur, and those circumstances may increase the ICP. So those should be prevented. Tandaan, bawal na magkaroon ang pasyente ng respiratory infection. Okay. In addition, in a care for a patient with increased ICP, tandaan natin to avoid the following activities. Ano yung mga activities na bawal? Such as coughing and sneezing, di ba? Blowing the nose. Lahat ng activities na nakapagpataas ng intra-abdominal and intrathoracic pressure. Kasi pag tumaas ang intra-abdominal and intrathoracic pressure, ano nangyari? Nagko-close ang glottis that leads into increased in ICP. So, bawal po ang mga activities na yon. What else? Bending and stooping should also be prevented. Valsalva maneuver. Okay, so that is the main problem pag meron tayong immobility caused by unconsciousness. So, possibly, ang Valsalva maneuver. So, bawal din po yon. So, that is why stool softener can be administered as ordered by the physician. Because Valsalva maneuver will increase ICP. And, in addition to that, bawal din po or avoid heavy lifting. So, those are the activities that may increase ICP. Okay, another nursing intervention. Nursing care po natin. Alright, supportive care. First, we need to maintain a patent airway for the patient. Now, how can we maintain a patent airway? First, by virtue of your suctioning. So, tandaan po natin, suctioning could be provided and suctioning should only be done as PRN. O, bakit bawal gawin ang suctioning frequently? Because when we perform frequent suctioning, it leads to vasovagal reflex stimulation that can lead into increased in ICP. Alright, so suctioning as PRN should be done, pero bawal ang frequent suctioning. In addition, to maintain a patent airway, we need also to position the patient in which we perform side lying with the head of bed elevated. Bakit side lying? Naka-side lying ang pasyente to prevent aspiration. Alright? And bakit kailangan naka-elevate ang head of bed? Kasi possibly tumataas ang ating ICP or intracranial pressure. So we have to maintain a patent airway. Second, in the supportive care, we need to promote the nutritional needs of the patient. Pag-usapan naman natin ng nutrition. Ano nga ang problema ng pasyente kapag may stroke? Meron siyang dysphagia. What is dysphagia? Again, difficulty of swallowing. The patient is at risk for aspiration. So that is why supplemental feeding should be performed. What do you mean by supplemental feeding? Pag sinabi kong supplemental feeding, it is through your NGT, nasogastric tube, or it could be through your TPN or total parenteral nutrition or your hyperalimentation. So, ipoprovide natin yon because they are at risk for aspiration. Some of the other patients can tolerate oral feeding. Meron iba sa kanila, yung merong slight neurologic deficit lamang, can tolerate oral feeding. So, in that case, if they can tolerate oral feeding, first and foremost, we need to check the gag reflex. Now, what is the best method to check gag reflex? Diba? We need to perform your swallowing test. Ano yung swallowing test? We let the patient sip a water progressively, unti-unti, dahan-dahan, iinom siya ng tubig, sip through a straw, and you need to observe if the client can tolerate the sipping of water. Then, if the patient can tolerate that sip of water, then pwede tayong mag-proceed sa oral feeding. The oral feeding that we have to provide is usually semi-solid. Pag sinabing semi-solid, that is soft food with thick fluids. Thickening of the fluids. Tandaan, kapag stroke yan, merong dysphagia, ano ang bawal? Thin, manipis. Ibig sabihin, yung mga malalabnaw na fluid, kailangan pinakapal na fluid ang kailangan po nating i-provide sa patient. Why? Kasi it easily forms into a bolus. Pag na-form yan into a bolus, mas madaling maswallow ng patient natin. So therefore, it should be of soft food. In addition, sabi natin, a patient with stroke has a weakness of the muscles of the face and the tongue. So therefore, if there is a weakness of the muscle of the face and the tongue, pwede din siyang ma-aspirate. So that is the main reason, i-add natin ang nursing intervention that we have to place the food and instruct the patient to chew the food on the unaffected side of the body. So that is what we call your promotion of nutrition. Okay, next one. Another, promote activity. Anong problem natin? You have your hemiparesis and hemiplegia. O, anong nangyari sa hemiplegia at hemiparesis? Weakness and paralysis. So therefore, the nursing diagnosis would be impaired physical mobility. Hindi siya makakagalaw, kaya nga complications of immobility may occur. So therefore, how are we going to promote activity? First, encourage deep breathing. Bakit kailangan mag-deep breathing? Kasi hindi nga sila nakakagalaw. So therefore, pwede silang magkaroon ng atelectasis. What is atelectasis? That is lung collapse. So, for the lungs to be kept expanded, we need to ask the client to perform deep breathing exercises. What else? Aside from that, ang pasyente, the half of the body has weakness. The half of the body ay meron po tayong tinatawag na paralysis. So, we need to turn the patient every 2 hours. Bakit kailangang i-turn siya? Because possible naman na magkaroon tayo ng pressure sore and atelectasis. Alright. What else? Aside from that activity, kailangan din po natin, kasi the patient will not be able to take care of him or herself, kailangan nating i-provide ang assistance with ADL. What do you mean by ADL? That is your activities of daily living. So we need to assist the patient with ADL. What else would be the problem? Another problem would be the decreased venous return. Ano nangyari? Venous stasis. No? So kasi hindi siya gumagalaw, so possible ang DVT or thrombosis. So therefore, para maiwasan natin ang thrombosis, anong gagawin po natin? Aside from turning of the patient, we need to provide active and passive range of motion exercises. Tandaan, the active range of motion exercises is provided to the unaffected side of the body, while the passive range of motion exercises is performed on the affected side of the body kasi possible ang thrombosis. At kapag may thrombosis, makikita mo possible ang redness dun sa impaired area. So that is why we need to promote your activity or your exercise. Alright. Another, promote elimination. How do you promote elimination? Tandaan, pag meron tayong severe stroke, possible ang hypertension. So, anong meron? Possible din ang increased ICP. So, ano ang bawal na bawal? Bawal na bawal po na magkaroon ng constipation. Because constipation can promote Valsalva maneuver, and Valsalva maneuver can increase the intracranial pressure. So, to prevent increase in ICP, to prevent Valsalva maneuver and constipation, we add fiber in the diet of the patient and sufficient fluids. In addition to that, we need to perform a scheduled voiding and scheduled defecation. Pag sinabi po nating scheduled voiding and defecation, yan yung tinatawag nating bladder and bowel retraining program. So, kasama sa elimination, bowel and bladder retraining program. Alright? So, that is scheduled defecation and urination. Okay, next one. We need also to promote communication. Ano nga ang problema natin pag may stroke problem? Dysarthria and aphasia. So therefore, you need to provide alternative methods of communication. So if the client has difficulty writing words, difficulty on speaking words, then we have to promote other alternative communication means. And of course, as a nurse, you need to provide or to promote therapeutic communication skills such as listening attentively, such as encouraging verbalization, waiting for the patient's responses, Okay? So they are your therapeutic communication. So promote communication of the patient. What else? Aside from that, sabi dito, we need to care for a patient with hemianopsia. Do you remember your hemianopsia? Hemianopsia is the loss of the half of the visual field. So therefore, meron tayong visual deficit. So anong gagawin natin pag may visual deficit? First, you need to encourage them to wear their eyeglasses. Okay? What else? You need also to place the objects or to approach the patient on the unaffected side of the body. Kung saan yung walang visual deficit, doon ka magpapakita, doon may ilalagay ang articles ng pasyente. Alright? What else aside from that? Okay, pinaka-common sa board exam. Ito yung tinatawag nating teach the patient about scanning technique. What do you mean by scanning technique? When we talk about scanning technique, you have to teach the client to look from the left to the right, or to the right to the left. Bakit kailangang i-scan ng pasyente ang environment? That is for safety. And in addition, that is also to compensate with the loss or the disability of the patient. So that is for a care for sensory problem. Alright, next. Rehabilitation. Pag sinabi natin rehabilitation, some of the patient can recover from stroke. So therefore, kung meron tayong problems with or disability or residuals of the patient, ano yung mga methods natin or mga measures? Una, proper referral. Okay, kanino natin i-refer? Refer the patient to PT and OT. Ano ang pagkakaiba? Pag sinabi kong PT, physical therapist. Pag sinabi kong OT, occupational therapist. Anong pagkakaiba nila? Physical therapist is involved whenever the patient has gross motor problem. Example would be your ambulation. No? So, pag problemang ambulation ng pasyenteng may stroke, kanino i-refer? Sa physical therapist. How about referral to occupational therapist? For occupational therapist, if the problem is fine motor skills, what are the examples of problem with fine motor skills? Using a utensils or writing. Okay, so pag may problem tayo on fine motor skills, then it should be referred to an occupational therapist. In addition, a patient can also be referred to speech therapist since the patient may have dysarthria or slurring of speech and your aphasia. In addition, patient may have sexual dysfunction. So to whom are we going to refer the patient? Sex therapist would be the person in charge or responsible for sexual needs of the patient. And last but not the least, most of the patient with disability coming from stroke could have depression, they could have emotional lability, irritability, and mood swings. So, yun yung manifestation nila. So, therefore, what we are going to do is to provide individual and group support. No? Individual group support not only to the patient, but to the families as well. So, bibigyan din po natin ng caregiver support, family support, and in addition, kailangan din po ng pasyente ng tinatawag po natin na promotion of the patient's self-esteem. Alright? So, they are what we call the most important nursing management in a patient with stroke. Okay, let's move on with your genitourinary disorders. Alright, so the most common question that is appearing in the boards is all about your renal failure. Alright, so we will be discussing your different types of renal failure. But before we proceed to that, let us review some of the functions of the kidney. The kidney, as a bean-shaped structure, which is located on the retroperitoneal area, has the function of waste elimination. Alright? So first, the function is it cleans the blood. Diba? So ibig sabihin, ito po ay more of filtering the blood. Alright? So how is it filtered? It is by means of the action of the nephrons. Okay. Now, sabi po natin, it cleans or it filters the blood. Alright? What else? Aside from that, when it filters the blood, it removes your waste products. How is it removed? Through your filtration, reabsorption, and secretion. So, pag nagkaroon na tayo ng tubular secretion, that's the time na nagkakaroon po tayo ng urine production. Alright. What are the other functions aside from that? Aside from cleansing of the blood or filtering of the blood, removal of waste products, it is also involved in fluid and electrolytes regulation. So, fluids and electrolyte regulation by means of your tubular reabsorption, by means of your ina-absorb niya muli yung mga electrolytes na kailangan or fluids, and some of the fluids and electrolytes that is in excess should be excreted into the system. What else? Your kidneys works also as a buffer system. What do you mean by buffer system? Pag sinabing buffer system, it is for neutralization or maintaining the normal pH of the blood, which is 7.35 to 7.45. Ano po? So therefore, para ma-maintain ang normal pH, kasama ito sa function ng ating kidneys. What else? Aside from that, another function of the kidney is also your hormonal production. What are those hormones? First hormone, you have your renin. You remember your renin. Renin, which is involved in blood pressure regulation. What else? It also secretes your hormone erythropoietin. What is erythropoietin? Erythropoietin is a hormone that is secreted by the kidney to stimulate the bone marrow to produce more RBC, okay? Or to produce your erythrocytes or red blood cells. And in addition, it also secretes your dihydroxyvitamin D. Dihydroxyvitamin D is a hormone so that the vitamin D or the calciferol will be produced. Once that this vitamin D is produced, it will what? It will promote the absorption of calcium. So they are what we call some of the major functions of the kidney. Alright, now, let's proceed with your disorder. We have reviewed the physiology. Now, we have first your acute renal failure. Now, what is acute renal failure? Acute renal failure is a reversible clinical syndrome. Alright, tandaan, reversible. There is a complete loss of kidney function, but usually this is reversible. Pag sinabi nga ulit natin reversible, bumabalik. Nawala lahat ng kidneys function, pero bumabalik siya. So ano ang ating problem po dito? What are the causes of acute renal failure? Causes? Alright, so we have your three causes of acute renal failure. You have what we call your pre-renal, you have also your intrarenal, and you have your post-renal. Okay, sa board exam, kailangan mong matandaan yung tatlong causations. Ano ang mga examples under pre-renal, intrarenal, and post-renal? Alright, pag sinabi nating pre-renal from the word pre, before the kidney. So therefore, the main problem is blood pressure or the blood supply. Alright? So, ang pinaka-problem pag pre-renal is the lack or deficiency of blood supply to the kidney. Therefore, di ba sabi natin, blood supply is needed by all organs or tissues. So, kapag nakulangan ng blood supply or nakulangan ng oxygen ang ating kidneys, it will be having their ischemia and hypoxia. That is why you will have your kidney failure. So first, pre-renal, it is caused by lack of blood supply to the kidneys. What are the examples? Examples such as bleeding or hemorrhage. Diba? Pag meron kang severe na bleeding or hemorrhage, ano po ang nangyayari? Pag may bleeding or hemorrhage, nakukulangan ng blood supply si kidney. What else? Aside from that, kasama pa sa ating pre-renal, blood pressure problems such as in the case of shock. No po? So not only bleeding but shock such as dehydration could be a cause of your pre-renal failure. Alright, next, second, intrarenal. When we talk about intrarenal problem is the direct insult to the kidney. Ibig sabihin, intrarenal within the kidney. There is a direct destruction or there is a direct damage into the kidney. What are the best example of direct damage to the kidney? Direct damage such as trauma. Right? So kapag na-traumatize ang kidney, example would be your gunshot wound. Another example would be your stab wounds. What else? Aside from that, inflammation. Do you remember your glomerulonephritis? An autoimmune condition. Inflammation of the kidney may cause also of its destruction. What else? Aside from that, kasama din po ang infection such as in the case of pyelonephritis. What else? Drugs and harmful substances to the kidney such as those drugs that could be potentially nephrotoxic. So, yun yung mga tinatawag po natin na direct insult to the kidney in which they are under your intrarenal. So, kailangan alam mo ang mga examples under those conditions. Alright. Last but not the least is your post-renal. Okay, pag sinabi po nating post-renal, post after the kidney. So, ibig sabihin, these are the conditions wherein the cause are obstruction. Alright, so what are the examples of those obstruction? Example would be your urolithiasis, stone formation, or your renal calculi. What else? Aside from that, kasama din po dyan yung tinatawag nating tumors and masses. What else? Benign prostatic hyperplasia, hypertrophy, those conditions that may cause urine flow obstruction. Bakit? Kasi ang normal na flow ng urine should be efflux. What do you mean by efflux? Pag sinabi kong efflux, from the kidneys going down to the ureter. So, ang problem natin, kapag may obstruction, there is a reflux. What do you mean by reflux? Pag sinabi nating reflux, it is a backflow. So, yung urine natin from the ureter bumabalik sa kidney. Kaya nga, nagkakaroon tayo ng hydronephrosis o nagkakaroon tayo ng damage sa kidney. So, tandaan, pag sinabi po nating post-renal failure, the cause is your obstruction. So, shall we review? What are the three causes of acute renal failure? You have your pre-renal, intrarenal, and post-renal. Pre-renal, the problem is lack of blood supply. Intrarenal, direct insult or damage to the kidney. And post-renal, it is caused by obstruction. Alright, now, we have clinical stages of our acute renal failure. So, these are the main clinical stages. First, oliguric. Second stage is diuretic phase. And the third one is your recovery period. Alright. When we talk about oliguric phase, from the word oliguric, ano bang ibig sabihin ng oliguria? Ibig sabihin, mababa ang alin? Mababa ang ating tinatawag na urine production. Mababa ang urine output. So, kung mababa ang urine output ng pasyente, the main problem here is your electrolyte imbalance. And the main electrolyte imbalance that is occurring whenever there is oliguria or a urine output that is less than 400 ml per day. Di ba? Ang normal urine output is 30 cc per day. So, therefore, kapag yan ay less than 30 cc, less than 30 ml per hour. The normal is 30 ml per hour. So, kapag ang urine output is less than 30 ml per hour or less than 400 ml per day, what would be the problem? It is your hyperkalemia. And what is the problem in hyperkalemia? The patient can have a dysrhythmias, abnormal conduction of the heart, in addition, weakness of the muscles, primarily the respiratory muscles may occur. So that is your oliguric phase. So in oliguric phase, ang mapapansin mo, there is decreased urine output of less than 400 ml per day. Alright, next one. Alright, the next phase is your diuretic phase. Alright, if the oliguric phase, the urine output is decreased, in the diuretic phase, the urine output is increased of 1 to 2 liters per day. So, masyadong marami naman ang ating urine output. Other references says until 5 liters per day. So, kapag masyadong mataas naman ang urine output, what would be the electrolyte problem naman natin? The electrolyte problem that may occur would be your hypokalemia. Okay? So, again, dysrhythmias can occur and weakness of the muscles can also occur. So, therefore, in the diuretic phase, there is an increase in the urine output of more than or equal to 2 liters per day. Okay? The last stage is your recovery period. In the recovery period, it entails going back to the normal condition of the kidneys. Ano nangyayari sa normal condition ng kidneys? Bumabalik yung tinatawag nating glomerular filtration rate. Okay. The normal glomerular filtration rate is 125 ml per minute. So, therefore, pag bumabalik na ang glomerular filtration rate, bumabalik na rin sa normal yung ating mga products. Okay. Or waste products, nitrogenous waste. So therefore, how would you know that the patient is on recovery period? It is by means of what? By means of normal BUN and creatinine level into the blood. Ano nga ba yung normal BUN natin? Yung normal BUN is ranging 10 to 20 mg per DL, and the normal creatinine level is 0.6 to 1.3 mg per DL. So, pag bumabalik na sa normal ang ating mga waste products, therefore, that is a recovery period. And usually, it entails for about 6 to 12 months before the recovery occurs. Alright? So, they are your 3 clinical stages. Once again, what are the 3 clinical stages? You have your oliguric, diuretic, and recovery phase. Again, oliguric, less than to 40 ml. The problem is hyperkalemia. Alright. In the diuretic, the problem is increased urine output of more than 2 liters per day. The electrolyte problem is hypokalemia. In recovery period, nagkakaroon na tayo ng normal. Okay? Normal of the glomerular filtration rate in which BUN and creatinine levels is a normal period for about 6 to 12 months. Alright. Now, let's talk about the clinical manifestations through your pathophysiologic occurrences. Alright. So, what happens in renal failure? Di ba sabi natin, it could be a pre-renal that causes destruction of the kidney. It could be an intrarenal causation. Pag sinabi nating intrarenal, it could be the direct damage to the kidney, or it could be what we call your post-renal. Alright, so what will happen if there is glomerular destruction? If the glomerulus is destroyed or damaged, ano nga ba ang role ng glomerulus? Glomerulus is for filtration. So what will happen if it's destroyed? There will be decreased glomerular filtration rate. Ano nga ang normal? The normal GFR is 125 ml per minute, di ba? So therefore, pag bumabagsak, anong tumataas ngayon? Tumataas ang mga waste products or nagiging excessive na yung ating electrolytes. Di ba sabi natin, electrolytes in excess should be excreted into the body. So first, ito ang mahalaga ha, tumataas ang BUN at creatinine. Naalala ang BUN, ang normal value natin, BUN is 10 to 20 mg per DL, di ba? Creatinine, normal is 0.6 to 1.3 mg per DL. Pag tumaas ang BUN at creatinine, that is the best reason kung bakit tayo nagkakaroon ng pruritus. Ang tawag natin doon is a condition uremic frost. What is pruritus? That is itchiness. So kung ang pasyente ay may itchiness, or pruritus, anong mangyayari? The patient will be at risk for skin breakdown. At kapag at risk na siya sa skin breakdown, bacterial infection can occur. Alright, what else? Drowsiness, headache, and seizure. Usually, these manifestations are caused by the increased level of BUN. So, say for example, this is the brain cell. Ito po yung ating blood or your blood-brain barrier. Kapag tumataas ang BUN, di ba sabi natin, principle of osmolality from the area of low concentration to high concentration. Tandaan, ang ating brain cells or the cells is only 0.9% NaCl. So therefore, kapag mataas po ang ating BUN component, it attracts the fluid from here, from the brain cells, palabas. So, anong mangyayari? Nagkakaroon tayo ng clinical manifestations or neurologic manifestations. Kaya nag-a-appear yung ating drowsiness, headache, and seizure. Alright, what else? Aside from that, you also have what we call the increase or excessive electrolytes in the body. One of the function of the kidney, diba, is to maintain a normal value of our electrolytes. Okay? So, therefore, anong mangyayari kapag sobrang naging excessive ang electrolytes? One of the electrolytes that should be controlled is your potassium level. Ilan nga po ang normal na potassium level natin? The normal potassium level is 3.5 to 5.0 mEq per liter. So, therefore, kapag kulang or mababa ang filtration rate, tumataas ang potassium more than 5. Pag tumataas ang serum potassium, what would be the problem? Pag tumataas ang serum potassium, it could be life-threatening. Why? Because it may result into the following manifestations. Alright. What are the manifestations of your patients with hyperkalemia? Patient will have your weak and irregular pulse. Nagkakaroon tayo ng dysrhythmias. Usual na dysrhythmias pag may hyperkalemia is your tall peak T wave, and then you have also your widened QRS complex. Abdominal pain or cramping will occur that may cause your diarrhea, and muscle weakness would also be the result. So this could be a life-threatening situation for the patient. So tandaan, pag kulang or mababa ang glomerular filtration rate, tumataas yung ating mga waste products. What else? Aside from that, hydrogen ion will also increase. Okay. Di ba sabi po natin, one of the major function also of the renal system is a buffer system that maintains acid-base regulation para ma-neutralize, ano po, by means of bicarbonate. So therefore, tumataas yung hydrogen ion. Tandaan, yung hydrogen ion po natin is acidic in nature. So that is why you will have your manifestations of metabolic acidosis. Alright. Now, what are the manifestations of metabolic acidosis? Such as the patient will have your fast, rapid, and increase in the depth of respiration. Anong tawag natin doon? That is your Kussmaul's respiration. What else are the other signs of metabolic acidosis? Nausea and vomiting, diarrhea, severe abdominal pain, and anorexia could also be the result. So those are the manifestation kapag may metabolic acidosis. Alright, another one. Sabi natin, the kidneys is involved in the regulation of electrolytes. Another electrolytes that needs to be regulated is your phosphate. So therefore, ano nangyayari? Tumataas ang phosphate. Tandaan po natin, class, that phosphate and your calcium is inversely proportional or inversely related. Anong ibig sabihin? Pag tumataas ang phosphate, ang calcium ay bumababa. Kapag ang phosphate ay bumababa, ang calcium naman ay tataas. That is vice versa, right? So therefore, in our case, hyperphosphatemia. So ano mangyayari sa calcium level? Bababa. Now, ano naman ang relationship po ng calcium sa ating muscle activity? Okay? Relationship po ng phosphate sa muscle ng calcium. Calcium is also inversely related to your muscle activity. So therefore, kung meron tayong mababa ang calcium, anong muscle activity? Tumataas. So there would be spasm. And spasm of the muscle is also known as tetany. Now, what are the signs and symptoms of tetany or signs and symptoms of hypocalcemia? First, you have your tingling sensation. What else? Aside from that, spasm of the face, spasm of the arms, tawag natin, it is your positive Vostek sign. When you tap the face, there would be unilateral twitching or spasm. Spasm of the arms or carpopedal spasm will occur. That is what we call your positive drususite. So, tandaan, signs of tetany, positive Vostek sign, and positive drususite. In addition, what is life-threatening in tetany is whenever the patient will have your laryngospasm. Pag laryngospasm, there would be breathing problem. So, therefore, if there would be your breathing problem, the patient can die from respiratory distress. Alright? So, that is what is happening if the glomerular filtration rate is decreased. Alright, let's move forward. Okay. You need also to remember that when the kidneys are destroyed, the blood supply is also damaged. Ano po? Nada-damage din po ang ating blood supply. So therefore, whenever there is glomerular destruction, the blood supply will be reduced. And when the blood supply is reduced, you will have your activation of RAAS. Okay, do you remember what do you mean by RAAS? RAAS means your renin, angiotensin, aldosterone system. Paano ito nangyayari? Sabi natin, renin is produced by what? It is produced by the kidneys. Whenever there is production of renin, anong kakambal ng renin? You have your angiotensinogen. Okay, tandaan, angiotensinogen is produced by the liver. Okay, so you have your renin, you also have your angiotensinogen. Alright. So therefore, whenever you have what we call your renin and angiotensinogen, it results into what? It results into the production of angiotensin 1. Okay, tandaan, is angiotensin 1 a potent vasoconstrictor? Not yet. Until such time that it will be converted into angiotensin 2. Okay, paano nako-convert ang angiotensin 1 sa angiotensin 2? It is by means of your ACE. Do you remember your ACE? What do you call your ACE? Angiotensin converting enzyme. Sino ang nag-release ng angiotensin converting enzyme? It is released by the lungs. So when the lungs release your angiotensin converting enzyme, thus angiotensin 1 can be converted into angiotensin 2, and at this point in time, angiotensin 2 now is a potent vasoconstrictor that leads to the development of hypertension. Tumataas na ngayon ang BP kapag merong renal failure. Alright? Now, what else aside from that? Renin and angiotensinogen can also lead into the production of angiotensin 3. Pag may angiotensin 3, mas-stimulate ang adrenal gland na produce ang hormone na aldosterone. Do you remember aldosterone? Aldosterone is a primary mineralocorticoid. What do you mean by mineralocorticoid? It promotes sodium retention. So therefore, pag na-release si aldosterone at meron kang sodium retention, water will also be retained. Tandaan, vice versa yan, di ba? So kapag sodium ay na-retain, water will also be retained because the sodium usually is hydrophilic. So that is why you have the presence of edema. Okay? So doon po nanggaling ang ating edema and hypertension. Oh, what else aside from that? When the glomerulus is also destroyed, it will also allow protein substances to pass through. Ano po? So, anong mangyayari? Pupunta sa urine ang protein. Okay. Anong tawag natin pag pumunta sa urine ang protein? Tatawagin nating proteinuria. Diba? Ano ba ang role ng protein? Specifically, the albumin. Specifically, class, the albumin controls the oncotic pressure. Alright. So, say for example, this is your cells. This is the blood. This is your albumin. Anong ginagawa ng albumin? Albumin, oncotic. What is the pressure in oncotic pressure? It is a pulling pressure. So, therefore, in the presence of albumin, it pulls the fluid going to the blood vessels or in the intravascular space. So therefore, kapag nagkaroon ng proteinuria, sumama ang protein sa urine, mauubos ang albumin saan? Sa blood. So whenever there is proteinuria, there would be hypoalbuminemia. And when hypoalbuminemia occurs, what will happen? There will be decreased oncotic pressure. And whenever there is decreased oncotic pressure, fluids will accumulate where? In the interstitial space. And this is another reason why edema is occurring. So dalawa po ang cause ng edema in a patient with renal failure. It's either the RAS activation or the loss of protein in the urine. Alright. Another one. Another function of the kidney is to produce your erythropoietin. Do you remember the hormone erythropoietin? Erythropoietin is for the stimulation of the bone marrow to produce RBC or erythrocyte. So therefore, kapag hindi nakaka-produce ang ating kidney ng erythropoietin, what will happen? Wala din tayong stimulation ng bone marrow. Bababa yung ating red blood cell. Ano ba ang mahalaga sa red blood cell? It carries oxygen. So therefore, kung kulang sa RBC, what will be the consequence? Anemia. That is why the patient will have fatigue, difficulty of breathing, pallor, and so forth and so on. So they are what we call the signs and symptoms of anemia caused by a decrease in erythropoietin level. So they are what we call the clinical manifestations and causations of its manifestation. All right. So let's now have your management. Okay. How are we going to manage a patient with acute renal failure? It could be through dialysis. Why? Dialysis, two types of dialysis is your hemodialysis and your peritoneal dialysis. Why? Because the glomerular filtration is affected. So therefore, in the principle of dialysis, it has the principle of what we call ultrafiltration, osmosis, and diffusion. Principle of ultrafiltration is for us to remove accumulated waste. Principle of osmosis is to remove the accumulated fluids or your swelling caused by your edema. So, para matanggal yung excessive fluids, that is your osmosis. And last but not the least is the principle of diffusion. Bakit kailangan ng ating dialysis? Para magkaroon tayo ng correction of your buffer system, correction of your metabolic acidosis through your diffusion of your bicarbonate. So, that is what we call your dialysis as your temporary treatment. What else? Aside from that, cation exchange resin. Okay. Pag sinabi po natin cation exchange resin, sodium should go in and potassium should go out. Naalala ba ano ang problem natin? Di ba ang problem natin mataas yung potassium? Is this life-threatening? Yes, of course, because it could cause your dysrhythmias, di ba? So therefore, ang goal natin, matanggal natin si potassium. So in cation exchange resin, the drug of choice is your kayexalate. Now, your kayexalate could be in the form of enema. Ano po? Anong action yan? Enema should be there for about, it should be retained for about 15 minutes, okay? And after which, anong mangyayari? Sodium will go in and potassium will go out. So that is the reason bakit binibigyan natin ng kayexalate or known as your cation exchange resin. Okay, in addition, we need also to provide your IV dextrose 50%, insulin, and calcium replacement. Let us try to understand the role of insulin for hyperkalemia. Alright, dito tayo. Diba, sabi natin, this is the cell, this is the blood. Pag nagbigay tayo ng dextrose, it is your glucose. Diba? Glucose needs to enter into the cell para magkaroon ng energy. Paano pumapasok ang glucose inside the cell? Through your insulin. So therefore, bigyan mo ng glucose siya kasamang insulin. Tandaan, glucose will immediately enter into the cell. Anong sasama kasabay ni glucose? Since mabilis ang pagpasok ni glucose inside the cell, potassium is an intracellular cation. Pag sinabing intracellular, dito siya nakatira sa loob ng cell. So, kasama ng glucose, papasok din ang potassium. Kaya, makokorek po natin ang potassium imbalance. So, but take note, you need to monitor for signs and symptoms of hypokalemia and hypoglycemia. So, that is the main reason bakit binibigay ang dextrose and insulin. Alright, next one, calcium replacement. Okay, anong calcium replacement? Pag IV yan, tawag natin calcium gluconate. Pag oral, calcium carbonate. So, for calcium replacement, di ba, sabi natin, bakit binibigyan? Kasi meron siyang hypocalcemia. Saan ang galing ang kanyang hypocalcemia? May hyperphosphatemia. So, ibig sabihin, pag ni-replace mo ang calcium, when calcium becomes normal, the phosphate level will also return into normal one. Okay? That is for the prevention of tetany that could be life-threatening. Alright, what else? Another management, diuretics. Ano ang problem natin ng ating patient? Patient has your edema or swelling. So, therefore, what is the role of diuretics? Diuretics will, what? Pampaihi siya. Okay? So, ibig sabihin yung accumulated fluids will be excreted into the body. Now, in your diuretics, dalawang klase meron tayo niyan. Ano? We have what we call your potassium wasting. Example would be your loop diuretic, furosemide Lasix. Or your potassium sparing, such as your spironolactone or your aldactone. Ano po? So therefore, tinitingnan muna natin ang potassium level ng pasyente before we have to provide your diuretics. Tandaan, one of the side effects of diuretic is orthostatic hypotension. So therefore, kung ito ay nakakababa ng BP, ano po ang mahalagang intervention before giving the drug? We need to first, check or monitor the patient's blood pressure before giving the drug and do not give if the blood pressure is low or hypotensive kasi nakakababa ito ng BP. In addition, pampaihi po ito. So that is why when you will be asked, when is the best time to administer the diuretics, your answer should be, it should be administered at daytime or in the morning. Why? Because if that would be given during the evening, the client will have a disturbed sleeping pattern. At the same time, the patient could be at risk for injury because they may go to the bathroom through and through. Alright? So that is all about your diuretics. Okay, next one, sodium bicarb. Bakit tayo nagbibigay ng sodium bicarb to a patient with acute renal failure? Because it is observable that the patient may have manifestations of metabolic acidosis. So sodium bicarbonate should be provided. Okay? And last but not the least, kasama din po ang phosphate binders. So, one of the example of your phosphate binders is your aluminum hydroxide. Ano po? So, kasama dyan ang aluminum hydroxide. Tandaan lamang ang complication ng phosphate binding agent. Sabi natin, pag nagbigay ka ng phosphate binding agent, we are going to lower the phosphate level. Ano naman ang tataas? Calcium level. So, therefore, anong mangyayari? Pag bumaba ang phosphate, tumaas ang calcium, calcium has inversely relationship with your muscle activity, magkakaroon ka naman ng muscle weakness. And that is why the reason na meron tayong constipation. Tandaan, pag hypercalcemia, you will have constipation. Hypocalcemia, you will have diarrhea. So yun yung reason kung bakit binibigay ang phosphate binding agent. So again, aluminum hydroxide, and the side effect is your constipation. Alright. Let's talk about now your nursing interventions for a patient with renal failure. Okay, first you have to monitor the intake and output. Why? It is observable that the patient with renal failure could be oliguric or on the diuretic phase, and that could be important in the determinant of your electrolyte problem. Weight should also be monitored. Bakit mino-monitor natin ang weight? Because it is expected that in a patient with renal failure, nagkakaroon tayo ng accumulation of fluids. Okay, and that accumulation of fluids may cause weight gain. And tandaan po natin, weight is the best indicator of the patient's fluid status. Alright, next one. Limit fluids. Pag sinabi nating limit fluids, it should only be 1.5 liters per day. Okay, bakit kailangan 1.5 liters per day? Ano nga ang meron sa atin? Meron tayong water retention, sodium retention. So, 1.5 liters per day should be provided only to the patient para hindi na tayo magkaroon ng further edema. Alright, bed rest. Why do we have to place the patient on bed rest? It's because a patient with renal failure has hypertension. So, bed rest should be provided. Semi-Fowler's position. Why? Possibly, kapag meron siyang fluid accumulation, nagkakaroon tayo ng pulmonary congestion or ascites that causes difficulty of breathing. That is why semi-Fowler's position is provided. Another one, protect from injury due to encephalopathy. Saan nga nanggaling ang encephalopathy? Nanggaling kapag mataas ang alin? Ang BUN. So that is why safety precaution, because they may have altered sensorium. So you have to raise the side rails and the bed should be placed on the lowest position as possible. Alright, another one, skin care is very important. Di ba sabi natin, meron siyang uremic frost, merong pruritus. Now, pag sinabi ko pong skin care, tandaan, in your emollient bath, we need to be sure that it is not alcohol-based. Bawal ang alcohol. Tandaan, lahat ng merong alcohol, okay, na inilalagay sa skin ay bawal. Bakit? Because alcohol may cause dryness of the skin that may lead to irritation. Usually, super fatted lotion is provided to prevent dryness. And the fingernails of the patient should be kept short to prevent scratching that may cause skin breakdown. Some of the other clients may be relieved by antipruritics and other lotions. Okay? So, pwede rin po ang antipruritics and your calamine lotion. Alright. How about the patient's diet? Okay. The patient's diet first is low to moderate protein. Okay, bakit kailangan low to moderate protein? Ano bang nangyayari? When we break down protein, ano ang end product ng protein? The end product of protein is your BUN. Urea. Diba? Pag na-end product niya, ammonia, diba? And after which, yung ammonia, i-convert ng liver into urea. Kaya nagkakaroon ng BUN. So therefore, kung itong nagiging cause, tumataas ang BUN, kailangan ang protein natin should only be low to moderate, since that is acute renal failure, to prevent further increase in the BUN. Alright. How about the fat? The fat is moderate to high, and the carbohydrate or caloric intake should be increased. Bakit? Usually, nagkakaroon sila ng anorexia, nagkakaroon tayo ng fatigue, di ba? And of course, the client will have nutritional problems. So that is why the caloric intake should be increased. Alright, another one. How about the electrolyte intake? Controlled sodium and potassium intake based on serum levels. So, if the patient is manifesting signs of edema or swelling, signs of fluid retention, then therefore we need to prevent or we need to avoid foods that is rich in sodium. Ano nga yung mga foods that is rich in sodium? Lahat ng mga foods that is processed. Okay? So lahat ng mga maaalat, kasama dyan yung processed food. Okay, in the natural food, ang kasama dyan ay yung tomato juice. Okay, pag nakita mo ang tomato juice, that is also rich in sodium. That should be avoided by the patient. Alright, potassium level can also be avoided. Saan mo naman matatagpuan? Depende sa values natin. So kapag may hyperkalemia ang pasyente caused by renal failure, we need to avoid foods that is rich in potassium. At saan mo naman matatagpuan ang mga foods rich in potassium? That is from fresh fruits and fresh vegetables such as spinach, strawberries, di ba? Bananas, avocados, citrus fruits, they are your rich source of potassium. In addition, kasama din po dyan yung mga dried fruits such as your raisins and prunes. So, di ba? So, it should be prevented or avoided. Alright. Calcium supplements should also be given varying on phosphate level. Di ba naalala? Calcium carbonate should be provided. Bakit? Kasi meron siyang hypocalcemia. At tandaan, ano ang possible problem? Di ba tetany could be the result. Not only tetany ang pwede mangyari, tingling sensation that may cause injury may be the result. Possible, pag yan ay hypocalcemia, possible din na magkaroon tayo ng diarrhea. And not only that, bleeding. Kasi mahalaga din po ang calcium is the source of clotting mechanism. So therefore, we need to supply the necessary calcium depending upon the phosphate. Magbibigay tayo ng calcium kung mababa ang level ng calcium at mataas ang phosphate level. Right? So they are your interventions for acute renal failure. Alright, let's move forward with your chronic renal failure. Dadagdagan lang natin ang mga manifestation. First, we need to compare it from acute. Diba sabi natin, acute renal failure is reversible. However, when we talk about it is a chronic renal failure, at this point in time, this is progressive, irreversible deterioration in renal function. Pag sinabi nating irreversible, the functioning cannot be recovered. Okay? So, yung function ng kidney, lahat yon ay mawawala. Hindi na siya bumabalik. Unlike with acute renal failure, possible bumalik siya within the span of 6 to 12 months. Right? So, ang problem natin dito, the total loss of kidney function, which is progressive and irreversible in nature. Alright. Now, what are the stages of chronic renal failure? Alright. Now, you have to take note of the normal GFR. Naalala nga, di ba? You have 125 ml per minute. Now, we have 4 stages. Okay, what are the 4 stages? First, renal reserve impairment. Second, renal insufficiency. Third, renal failure. And last is your end-stage renal disease or your uremia. Now, kapag sinabi po nating first one or your renal reserve impairment, the GFR is 40 to 50%. So, yung GFR na 125 na nga nasa 70, nasa kalahati lang, 60 and above. Okay, 65 siguro. 40 to 50% lamang. Alright? So, half nung ating GFR is lost. Okay? How about your renal insufficiency? In renal insufficiency, natitira na lamang na GFR po natin would be 20 to 40%. In renal failure, ilan na lamang nephrons or ang ating GFR na nagpa-function? 10 to 20%. And your end-stage renal disease is only less than 10%. At this point in time, ito na yung nangangailangan ng chronic dialysis use and also nangangailangan na rin yan ng renal transplant. Alright? So, they are your stages. Now, what are the possible causations through this? Okay, causations. Naalala yung ating causations sa acute renal failure? Same. These are some of the causes. Infection, UTI. Diba? Pyelonephritis. Ito yon. Infection. Okay, or your pyelonephritis. Destruction of the kidneys caused by infection. What else? It could be caused by polycystic kidney disease. Ano yan? Ito yung mga tinatawag nating cellular aberration, cysts that is appearing, mga malignancies, okay, and cysts that is occurring. What else? Aside from that, obstructions. Another cause is your obstruction. So, possible din yan. Okay. Another one, meron siyang mga secondary diseases. Okay, such as chronic hypertension, diabetes, di ba? Thrombus formation, yung embolus natin, yung clot natin na dislodge, alright? So, pwede yung madislodge sa kidney that causes renal failure. And drugs, which are nephrotoxic in nature. So, ito yung mga causations. Ibig sabihin, pang matagalan na. Matagal na nagkakaroon ng problem ang ating patients. Alright, now, dagdagan natin ang clinical manifestations sa acute renal failure versus chronic. Sa chronic, ito yung mga additional manifestations. Alright. Kapag mataas ang BUN and creatinine, patient will manifest your encephalopathy. Okay? Naka-highlight yan. Encephalopathy, anong ibig sabihin pag encephalopathy? Nagkakaroon tayo ng alteration of sensorium. Since tumataas ang BUN at creatinine, hindi lang azotemia. You have also manifestations of uremia. Now, what is the difference between azotemia and uremia? Naalala ba? Pag azotemia, tumataas lamang ang BUN and creatinine in the laboratory value. Maliwanag, azotemia pa lang ha. Mataas lang ang BUN at crea in the laboratory value. However, pag sinabi na po nating uremia, ang makikita na natin dito sa chronic renal failure is uremia. Pag uremia yan, mataas ang BUN and creatinine in the laboratory values and also mataas din ang ating or nakikita din ang maraming clinical manifestation. So, ibig sabihin, with clinical symptoms pag uremia. So, yun nga yung clinical symptoms ng uremia. You have your encephalopathy. Okay. What else? Aside from encephalopathy, you have also your pericarditis. So, yung BUN and creatinine are also what? Adhering to the pericardium that may cause pericarditis. What else? Aside from pericarditis, you have also your uremic fetor. Anong ibig sabihin ng uremic fetor? The breath of the patient, okay, would also be affected. Okay. And also, the patient will manifest peripheral neuropathy. Okay. What do you mean by neuropathy? Pag mataas ang BUN at creatinine, the patient will have numbness of the peripheral area. Okay. What else? Aside from that, to continue, they could have severe hyperkalemia caused by inability to excrete your potassium. And in a patient with chronic hypocalcemia, they will have osteodystrophy. What do you mean by osteodystrophy? Pag pinag-usapan natin ng osteodystrophy, at risk siya in the development of what? Fracture. So, pag mga chronic na po yan, what do you mean by fracture? It is the break in the bone integrity. So, therefore, kapag ang pasyente ay merong chronic renal failure, possible na sila na magkaroon ng fracture, okay, caused by a prolonged hypocalcemia. Okay. In addition, they will also have manifestations of, dahil meron na tayong glomerular destruction, possible din ang infection. So, they are at risk for infection. They have impaired wound healing. Bakit? Because of your BUN and creatinine that may cause hyperviscosity of the blood. What else? Aside from that, because of severe na retention of fluids, severe sodium retention, nagkakaroon na tayo not only edema, but rather you will have pulmonary congestion and heart failure. Next slide, please. You will have your pulmonary congestion and your heart failure. So, ito yung nagiging cause. Kanina, the RAS activation is only having edema and hypertension. But for this case, you will now have congestion of different organs in the body. And also, the anemia could be severe. Alright. So, for you to understand further, this is a picture of a patient with chronic renal failure of different stages. So, the first is your diminished renal reserve. Okay? So, ito pa ang ating appearance of the patient. So, usually, azotemia pa lamang yan. Mataas pa lang ang BUN and crea in the clinical value. However, if that is renal insufficiency, tumataas ng BUN at crea, plus nagkakaroon ng manifestations, so therefore, patient could have edema, hypertension, anemia, and so forth and so on. Okay. And if the patient is now on end stage, okay, ito na yung appearance ng pasyente, they will have now the clinical manifestations and the complications of your renal failure. What are those complications? Diba? Diniscuss natin, encephalopathy, neurological problem. Ito yan, no? Confusion, changes of sensorium, nagkakaroon na siya ng problem. What else? Cardiovascular, di ba may pericarditis? So, pwedeng tumaas ang BP, nagkakaroon tayo ng heart failure. What else? Aside from that, okay, nagkakaroon din tayo ng presence of ulcers. Okay, ulcers sa GI tract. Okay? So, GI tract, possible ang ulceration. Ito na yung tinatawag po natin na stress ulcer. Okay? And other manifestations or a holistic manifestation from head to foot, lahat po yan is affected. Okay? As I have discussed a while ago. Alright. Now, what are the collaborative management? Okay. Collaborative management for a patient, again, dialysis, okay, usually lifetime scheduled dialysis, and or renal transplant. Alright? So, dahil yan ay chronic na, before, sabi natin, temporary lang pag acute. Pero pag chronic, it could be lifetime. Okay. What else? Phosphate binding agent. Do you remember your phosphate binding agent? Example is your aluminum hydroxide. Kapag bumaba ang phosphate, ang calcium level ay tataas naman, magno-normalize sila pareho. Ano nga lamang ang important side effect ng phosphate binding agent such as aluminum hydroxide? It causes constipation. Alright.